Hi, I'm Amithyse Moore, and the brain disorder and deficit I will be discussing in this presentation is Pick's disease and the protein accumulation, motor neuron degeneration, and lobar atrophy deficits associated with this disease. Pick's disease is a form of dementia characterized by behavioral changes such as deterioration of social skills and changes in personality. Intellectual impairment, memory loss, and language deterioration may also occur. Pick disease is rare. However, it is responsible for 6 to 15% of all dementia cases, and a genetic form of the disease is also recognized. Although a progressive form of communication impairment, aphasia, may occur as part of Pick's disease, people with Pick's disease typically live with behavioral problems besides language and communication impairment. For the purposes of this presentation, I will focus on the neuropathologic and neurological dysfunctions. What causes Pick's disease? The specific cause of Pick's disease is unknown. However, it is an accumulation of Pick bodies or protein cells. One will not know if they've truly had Pick's disease until they've already died. As many as 50% of patients with frontotemporal dementia have a positive family history of dementia and inherit frontotemporal dementia as an autosomal dominant trait with high penetrance. Pick's disease is synonymous with frontotemporal dementia, and it is sometimes used to specifically refer to the clinical phenotype of the frontotemporal dementias. This group of disorders has a variety of pathologic components, the most prevalent of which is frontotemporal lobar degeneration and tau protein, structures of the cell that form larger structural cells, and their dysfunction. The typical onset of Pick's disease is in the 50s, but it has also been reported to begin as early as the late 20s and as late as in someone's 80s. Most common cases of familial PD are in Europe. More men than women are affected, however, both have equal risk. Pick's disease occurs typically when someone's younger, but the peak age occurs between 55 and 65. Those with Pick's disease typically live shorter lifespans than those with Alzheimer's or progressive aphasia or other dementias. How will you know you have it? While you're alive? That answer will not be easy. Again, diagnosis is official upon autopsy. However, if you have a skilled enough neurologist or physician examining you, they may be able to diagnose you within a form of dementia. If that is the case, the disorder can be tracked in phases. The phases are defined by the extent of the regional involvement of tau pathology across all cases, beginning with phase 1, where the disease is restricted to limbic and neurocortical frontal temporal regions and angular gyrus. Phase 2, degenerations continue to the white matter tracts, subcortical structures, and serotogenic and noradrenergic brainstem nuclei. Phase 3, tau neuropathology is witnessed in the primary motor cortex and pre-cerebellar nuclei in the medulla. Finally, during phase 4, is the most severe tau pathology. Tau proteins and tau deposits are really burdening the brain, especially within the visual cortex and variably throughout the cerebellar granular layer and the brainstem white matter. In the picture to the right, there are pictures of brains that have Pick's disease, and you see that the disease is worsening, starting with the top left, going down to the bottom, then going to the bottom of the right side, and back up to the top of the right side. You can see how the brain structures increase in severity and the damage worsens. What structures of the brain are affected? Pick's disease will affect both brain structure and function. Arnold Pick described the clinical picture of Pick's disease as frontotemporal atrophy over a century ago. Pick's initial case involved a progressive aphasic patient with behavioral disturbances. The patient only received gross examination, that means without any microscopic data. Nonetheless, the clinical description and its relationship to focal atrophy is the basis of the disease. Again, Pick's disease requires differential diagnosis and an autopsy to verify one has had or has the disease. The process of diagnosis requires brain scans, cognitive testing, personality surveying, and cellular analysis. Grossly, we know that the brains of a person with a normal brain and a Pick's disease are very different. An individual with Pick's disease will display drastic bifrontal temporal atrophy indenting of the frontal and temporal sulci, as well as dilated ventricles, which means larger ventricles. Studies have shown that with microcellular analysis, individuals with Pick's disease will exhibit a loss of large pyramidal neurons, abnormalities in surviving pyramidal neurons, and they also have silver staining, which is a depiction of neural damage. They have diffuse spongiosis and gliosis. Gliosis is a really big deal because it's the scarring of the central nervous system after a cell neuron has died. So the cell neuron is already dead, which is problematic, but also once that neuron is scarred, it can inhibit other pathways and the overall connectivity of the brain. We can see in the pictures on this slide, in the picture above, we have a normal brain, normal density, and normal ventricle size. However, the picture below, you see the drastic bifrontal temporal atrophy. Right in the center, it's clear that that part of the brain is shrinking and diminishing. You can also see knife-like projections. Within these projections, within the sulci, there is the ballooning of the Pick body cells, and those Pick body cells are growing and developing and worsening, and those tau proteins are accumulating and getting more and more stuck within the brain and really beginning to affect that person. How exactly is brain function impaired? Brain function is impaired through implications associated with lobular atrophy, neuronal loss, and tau protein abnormal pathologies. Pick's disease is most commonly associated with the disorder of social conduct and executive impairments, known as the behavioral variant of the frontotemporal dementia. Behavioral variant meaning the way you can differentiate the diagnosis of dementias. An individual demonstrating signs of Pick's disease is likely to appear to be a different person. They have a different personality or changes in their likes and dislikes, and their temperament can also significantly alter. They might also manifest progressive disorder of language, usually with the primary progressive aphasia, or less commonly, they might be akinetic, showing a more rigid syndrome, and that can affect their executive, praxis, and visual spatial skills. On this slide, you can see an affected Pick's disease brain. So there's clear shrinking or atrophy of the brain. We have some neuronal loss and scarring at that top layer of the brain, right by the frontal area. You can also see that the premotor cortex and several sulci are getting infected and scarring. Likewise, you see in the picture below that those areas that are affected at the top part of the brain, you can see what their functions were. So as the brain begins to shrink and neurons begin to scar, you get the problems associated with damage in the frontal lobes, associated with language, decision-making, personality changes, and henceforth. How will I, an SLP, help a patient with Pick's disease? First of all, luckily, we are not involved in the diagnosis process. So that takes one large step out of our hands. So when we get our client and we know that they do have Pick's disease or they have signs and symptoms that are associated with Pick's disease, we need to look for the symptoms that are associated with language and cognition and social skills, things that are in our realm of treating. With that said, the symptoms you may see as a healthcare provider are varied. Nonetheless, the speech therapist on the case will check for impairments that correspond to the neurological damage. In most cases, that means watching for language symptoms, as we know that the frontal and temporal portions of the brain, which are most commonly used for understanding and executing language, are impacted. So when we're looking for language problems, we're watching for repetition of words spoken by another person, exhibiting qualities of being echolalic, difficulty speaking, difficulty initiating speech, lack of speech, trouble finding words, decreased reading and writing comprehension. Likewise, their voice might sound slurred and garbled. and the cadence of the speech may change so that the person with the disease is hard to understand. This can also be seen by the family members as personality changes, changes in their tone and the words they use that are very unfamiliar to how they were talking before. The person with Pick's disease may begin to speak too loud or too soft or violate conversational rules that they don't know they're violating. For example, they might come in closer to talk to you or get much farther away, making it very uncomfortable and difficult to engage in a conversation. Some people with Pick's disease may also lose the ability to link spoken and written words with meaning, which is affiliated with the semantic dementia. As if language can no longer spark complex thinking and associations in their mind, a person with Pick's disease kind of has an overall confused state at times when engaging in conversation that they might not have initiated. So these are things that we can look for with their language problems. But again, a lot of the information you get will come from the family that deal with behavioral and emotional changes, as well as changes in their cognitive state, emotional, behavioral, and language state will all point to signs that differentiate Pick's disease from other dementias. Seems like really complicated stuff, but it's actually not that bad. Although not scary stuff to us practicing clinicians, it can be scary stuff to the family member. So we need to remember that when working with these patients, to remind them that currently there is no cure, but research is ongoing and studies are progressing to help us better understand these patients and better treat them, and hopefully lead to better and longer life qualities and lifespans for these individuals. Likewise, it's very hard to live with any form of dementia or any form of a disease or disorder, let alone Pick's disease. So we have to counsel the individual, their family members, and caretakers, and really work on a legitimate, effective habilitation plan for everyone involved with that individual. It's a must. That concludes my presentation on Pick's disease. Please feel free to educate yourself even further with some of these references. Really good stuff. Hope you guys enjoyed this.